Okay, yeah.
You can go live now.
Hello. Good afternoon, everyone. Good afternoon from Hetero Healthcare. Good afternoon, Dr. Sunita. Dr. Sunita, thanks for joining the webinar about CARBETOCIN. CARBETOCIN is a brand introduced by Hetero Healthcare in past 6 months, and we are doing good with that. And however, there are many questions in the mind of our fellow doctors regarding the use of CARBETOCIN and how CARBETOCIN is better than the other UTEROTONIC. So first, I'll introduce Dr. Sunita Chandra. Sunita Chandra, Dr. Ma'am. She is director, Rajendra Nagar Hospital and IVF Center. She's associated with Morphis Lucknow Fertility Center. She's the advisory board member of IFS UP chapter. She is the chairperson, medical legal committee. She is member Quality Council of India. She is executive member of ISOPAB Lucknow. She is the president of AGPL Lucknow. She is also associated with LO GS as joint secretary, past secretary AG, APGL, founder, joint secretary, IFS, secretary, IFS, UP chapter. Ma'am has received a lot of awards and achievement. Best e-poster was awarded for Fertivision 2020. She has many publications published on account of her. She is awarded ABP News UP Brand Leadership Award. She is honored Gomti Gaurav Award. She is awarded Sanyogta Mahajan Memorial Award. She is honored with Chikitsa Ratna Award in 2022. Honored by Dainik Jagran for the best contribution in the field of women healthcare in 2023. She is active socially, academically, and even in cultural platforms. So I welcome you, Dr. Sunita ma'am. Please, highlight some good points over the use of CARBETOCIN on its clinical practices, how it is better than the other UTEROTONICs. Dr. Sunita.
Yeah. Thank you, Dr. Anjali. Thank you, Anjali. Thank you so much for giving me this opportunity. I'm just going to share my slides. So today we are going to talk on a very, very important topic, and that is postpartum hemorrhage. I think postpartum hemorrhage is a nightmare for all the obstetricians, whether they are still in college, I mean, they are doing their residency, MSMD, or they have passed, they are practicing anywhere in the world. So PPH, postpartum hemorrhage, remains a nightmare for all of us, all the obstetricians. So it is really important to know about postpartum hemorrhage. So all the audience, I'm sure they must be knowing what is PPH. I'll just go through it. Very quick revision of PPH. So if it is more than 500 ml following vaginal delivery, it is PPH. And if it is more than 1000 ml following cesarean delivery, then we call it PPH, or any amount of blood loss within 24 hours of delivery, where you see that patient's pulse is fast, that means she's tachycardic, or her blood pressure is low and down, and her pets are soaking, she's lying in pool of blood, then it is PPH. So what is primary PPH? It is first 24 hours of delivery, it is primary, and when it happens 24 hours to 12 weeks after delivery, it is secondary PPH. PPH is very unfortunate part in anybody's practice, but it is very common. So it is a very, very leading cause of maternal mortality, accounting for almost 35% of all maternal deaths. And it's really important because the burden is very, very high. It's a preventable condition. It is a manageable condition, but sometimes you really cannot do anything, and unfortunate events happen. Maternal mortality rate in developing countries was 240 per 100,000 live births in comparison to 16 in developed countries, which is very, very high in developing countries. Globally, if we see the burden of PPH, it is 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery. and 6% after cesarean section. In India, 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH. So in India, the burden is very high, but if you see the globally, also PPH is very, the burden of PPH is very high. So what happens? Why are we actually bothered about PPH? Why? Because it's a serious condition. Okay. Second thing, it actually not only relates to the patient, but their family. In terms of significant increase in hospital stay, there is need of blood transfusions. You have to actually make them rush to arrange bloods, which they are not prepared for. Higher patients' mortality, major impact on lives and health of the affected and their families, and long-term psychological impact. What we call is post-traumatic stress disorder, PTSD. That means chances of postpartum psychosis is much more in patients who have suffered from PPH. And what are the causes of PPH? As we were studying since beginning, 4 important things, 4 T's. That is tone, trauma, tissue, and thrombin. Tone means atonic uterus, which is approximately 70% of patients of PPH have atonic uterus at some time or other, and 20% have some lacerations, hematomas, inversion, or rupture, and 10% actually have some kinds of retained tissue or invasive placenta. Placenta is not being removed properly, that is why they keep on bleeding. And 1% may have coagulopathies, which were not diagnosed earlier when she was pregnant. It is only diagnosed when she has PPH, and you wonder, there is nothing, then why is she bleeding? And then you come to know that she is having some kind of coagulopathy. But the most common cause of postpartum hemorrhage still remains uterine atony, which is very common. And this results in poor contraction of uterus, and that is why they keep on bleeding. So what are the risk factors of PPH, where we can really anticipate that these patients can go into PPH? One is prolonged labor. All of us know that. Grand multipara. Yes. हम लोग कॉलेज में थे तब भी पढ़ाया जाता था कि देखो इसका she is multipara, she is grand multi, she is 4th gravida, 5th gravida, इसका blood arrange कर लो, she can go into PPH. Augmented and precipitate labor, again they are more prone for PPH. History of PPH यदि previous pregnancy में है, then these patients are always prone for PPH in other pregnancies also. Over distended uterus, all of us know whether it is a macrosomic baby, twins, or polyhydramnios. If the uterus is over distended, they have a large surface of placenta, and that placental surface keeps on bleeding. So it's a norm actually now that if the patient is having over distended uterus, she is twins or triplets or polyhydramnios, then it is our duty to arrange blood in anticipation prior to delivery, so that if needed, blood transfusion can be done. And we can take all other measures to prevent PPH in these patients. Operative delivery, more prone for PPH, and chorioamnitis. If the patient is leaking for a longer time, she's having a dirty vaginal discharge, a smelly discharge, that means chorioamnitis is settling in. And these patients again are more prone for PPH. So how do we diagnose? So one is like you do evaluation, you see her pallor, by examination, by just seeing that she's getting pale. Second, air hunger. These patients, they become hypoxic. Third, sweating all over the body. And tachycardia, and the most important is hypotension. If there is tachycardia and hypotension, then it is very important. That means she is bleeding a lot. Then we examine the patient, especially from vaginal. There is any vaginal laceration, cervix laceration, and if it is a cesarean, then there may be something upper than cervix, and you see for the signs of hematomas, uterine rupture, and if there is any retained placental tissue, can be seen by ultrasound. So all the uterine inversion has to be checked. So all these things has to be done. Then we send immediately side by side blood for hemoglobin, hematocrit, and platelets, and coagulation studies and assessment of fibrinogen. So what are the complications? Postpartum depression, as I said, and because of anterior pituitary ischemia, There may be Sheehan syndrome-like thing. There may be delay or failure of lactation, and maybe that patient do not bleed at all. She may go into amenorrhea forever. Anemia and fatigue, because she has lost so much of blood. Blood transfusions are needed in these patients. These are life-saving things. Myocardial ischemia can occur in these patients. They can go into dilutional coagulopathy, and finally, mortality can happen. So active management of third stage of labor is actually needed. Since we are studying, since we were there in medical college for our undergraduate or postgraduate, we always were taught that third stage should be actively managed. You should give 10 units of uterotonics immediately after delivery of anterior shoulder, control cord traction, and bimanual uterine massage. So third stage of labor should be managed with active management. Active management can speed up the delivery of placenta and lowers the risk of heavy bleeding. One is inject uterotonic agent immediately for contraction of womb. Second, delayed clamping for at least 1 to 3 minutes and control cord traction if required. And third, assess uterine tone immediately to ensure contracted uterus. A large WHO-directed multi-center clinical trial has highlighted the use of uterotonics as the most important part of active management of third stage of labor. PPH after cesarean delivery is more likely to happen in comparison to vaginal deliveries. Approximately 36% of cesarean deliveries are complicated by PPH, and therefore it is common practice to give a uterotonic drug following delivery of neonate during cesarean section. So it was international consensus in 2019 on the use of uterotonic agents during cesarean section. Uterotonic agents like oxytocin, CARBETOCINs are recommended for routine administration immediately after delivery of the fetus during cesarean section to prevent postpartum hemorrhage. So, how do we prevent PPH? For anything, prevention is better than cure. So, if we predict that this patient can go into PPH, we can really prevent. We are prepared with everything, with all the uterotonics, blood, and our staff is prepared. We are prepared, patient is prepared, attendants are prepared. So one is you improve the health of the patient, like hemoglobin should be maintained around 11 or more than 11. If she is not anemic beforehand, I mean, it is really good that she can sustain of some blood loss. Second, identification of high-risk women is very, very important. Plan for institutional deliveries for all the patients. A strict vigilance of all women in third stage of labor is very, very important. Proactive, active management of third stage of labor in all. Examination of afterbirth, that means placenta should be examined properly, it should be routine. And examination of uterovaginal canal following difficult or instrumental delivery. So now let's see what are the uterotonic drugs. First line is oxytocin and carbetocin. And second line is ergot alkaloids like ergometrin, methylergometrin, and prostaglandins and its analog like PGE2, misoprostol, and carboprost. But oxytocin was considered as a gold standard treatment for the prevention of PPH. So only thing is that oxytocin is short acting. Its half-life is 4 to 10 minutes. Duration of action is 15 to 20 minutes. So once you give one IV bolus, you have to give IV infusion for around 4 to 6 hours, maybe more if needed. And because of prolonged infusion, it desensitizes the oxytocin receptors. So even if you are giving oxytocin in infusion, the effect on the uterus is not there, and uterus does not contract, makes the uterus atonic. So important is that it is short acting and it causes receptor desensitization. That is why it is important that we have to see something which can be used and it gives a longer duration of action. Variation in doses is there. All of us know that there is no strict guideline on the doses of oxytocin. There is no strict regime for this. And it is a high alert medication because sometimes it can cause hypertension, sometimes it can cause arrhythmias, pulse irregularities, and all of us know it acts as antidiuretic hormone, so it can cause hyponatremia also in some patients if you are giving it for a longer time. When do we use uterotonics? One is at the crowning of baby's head, at delivery of anterior shoulder, at the end of second stage of labor, or the following delivery of the placenta. And sometimes we use it prophylactically to prevent PPH, and we use routinely routinely for active management of third stage of labor. And therapeutically, again, these uterotonics are used for management of PPH. So the need of the hour is that we should have a longer acting drug, single dose of administration, no variation in dosage regimes, devoid of repeated administration, ease of one-time administration, superior efficacy or similar efficacy as that of oxytocin, which we are using for a long time, and devoid of receptor desensitization and superior side effect profile over oxytocin. So WHO recommends use of carbetocin. WHO recommends use of an effective uterotonic for the prevention of PPH during the third stage. To effectively prevent PPH, only one uterotonic should be used, and uterotonics can be oxytocin, carbetocin, misoprostol, methylargometrine, oxytocin and argometrine fixed dose combinations. Anything can be there. So what is carbetocin? Let's see. Carbetocin is like there was some modification in oxytocin structure and carbetocin was made. It has a prolonged half-life, and that is why it reduces enzymatic degradation. It's long-acting analog of oxytocin. Indication all of us know is for PPH due to uterine atony, and it comes in a vial of 1 ml, which contains 100 microgram solution for injection. How does it act? It acts by acting through oxytocin receptors, which causes the uterus to contract. So it is oxytocic, uterotonic, and anti-hemorrhagic because it causes some thickening of the blood also. So carbetocin mechanism of action, receptor binding triggers activation of phospholipase C and generation of the second messengers IP and diacylglycerol. IP3 induces release of free calcium from intracellular stores. Binding of calcium to calmodium stimulates uterine smooth muscles contractions. So this is very important for us by activation of myosin light chain kinase. So a single dose of carbetocin 100 microgram administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and excessive bleeding, and it is more efficacious than continuous oxytocin infusion. So if we compare carbetocin versus oxytocin, oxytocin has a shorter half-life, while carbetocin is half-life is 40 minutes, that means 10 folds higher. Duration of action is longer, whether it is used IV or IM. It was found that a single intravenous bolus injection of carbetocin was at least as effective as 16 hours of continuous oxytocin infusion. There is no need to give it in a repeated doses. No dose variation, single dose of carbetocin is found to be effective in controlling PPH, unlike oxytocin. And even more important part is that it is heat stable. So there are 3-4 things. One is it is half-life is short, so it acts very fast. Half-life is long, so the effect is for a longer time. Second thing, it acts very fast. Third is there is no need to give any repeated administration. And it is not heat labile, it is heat stable. And it doesn't have any antidiuretic effect, so there is no question of hyponatremia. So carbetocin is recommended by WHO as an effective uterotonic in its 2018 guidelines, while carboprost is not recommended by WHO since it is associated with increased risk of diarrhea, vomiting, and sometimes even high temperature. Contraindications of carbetocin: epilepsy, eclampsia. If a patient is hypertensive, you have to use in caution, and it should not be given before delivery because it may cause respiratory or cardiac distress in mother or baby. So now let's see the clinical trials, oxytocin versus carbetocin. So carbetocin for the prevention of postpartum hemorrhage, a review of clinical effectiveness, cost effectiveness, and guidelines. So it was concluded that there was evidence of demonstrating carbetocin Similarly, or more effective than oxytocin for prevention of PPH, especially for cesarean section. Carbetocin was considered more cost-effective than oxytocin because you just have to give one bolus. This was a meta-analysis effect of carbetocin on PPH after vaginal delivery. Carbetocin is superior to oxytocin in preventing PPH among women with vaginal delivery. So that was for cesarean. This is for, and this is very latest paper of 2022. Again in PubMed. Heat-stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. Heat-stable carbetocin was non-inferior to oxytocin for the prevention of blood loss for at least 500 ml or the use of additional uterotonic agents. This was again in International Journal of Obs and Gynae, very latest paper, where a randomized control trial was done comparing carbetocin, misoprostol, and oxytocin for the prevention of PPH. It was seen that additional uterotonics were needed less frequently by patients treated with carbetocin. Carbetocin was comparable to oxytocin and superior to misoprostol in prevention of uterine atony following an elective cesarean delivery. So this was a very good RCT where they compared all three things, oxytocin, carbetocin, and misoprostol, and it was found that carbetocin was superior to both. This was again very nice study where they compared carbetocin versus oxytocin versus misoprost. 263 patients were taken. Carbetocin was giving 100 microgram, oxytocin 10 units immediately after delivery of shoulder, and 20 units in 500 saline IV for 4 hours or 400 microgram misoprostol sublingually. Primary outcome was occurrence of uterine atony necessitating additional uterotonics. And it was seen that additional uterotonics were needed less frequently by the patients who were treated with carbetocin. So it appears to be an attractive alternative to compare in comparison to oxytocin and misoprostol. This was again a comparative study between effect of carbetocin and oxytocin in isoflurane-induced uterine hypotonia. That means the patients who had twin pregnancy and who were, they had cesarean under GA and they were induced with isoflurane. Single dose of carbetocin appears to be more effective than oxytocin for several hours of uterine contraction, thus preventing postpartum hemorrhage in multiple pregnancy patients undergoing elective cesarean section. So this was in twin pregnancy. Now let's see the Cochrane review. In Cochrane review also, it was seen that carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. There is no difference in the incidence of PPH. Carbetocin was associated with less blood loss compared to symptomatrin in prevention of PPH. This was a champion trial, which is actually very much discussed in relation to carbetocin, where the study was done on 23 centers, including 10 countries, including India. We had few centers in India. Carbetocin, the important being like Institute of Medical Sciences, Banaras, Varanasi, then we had Cuttack, B.M. Patil Medical College, Karnataka, and so many colleges from India. So this was a large study across in 10 countries, including India. In this, carbetocin proved to be non-inferior to oxytocin with ease of single-dose administration. So now let's summarize what is PPH and what should we do. Postpartum hemorrhage remains a clinically significant cause of maternal complications and death. PPH is common and can occur in women who are not at risk. I mean, it's not necessary that all high-risk patients will have PPH. A patient who delivers normally, you will not even think about it that she can go into PPH and she can have PPH. PPH has a major impact on the lives and health of the affected and their families. WHO recommends the use of prophylactic uterotonic as an important step in active management of third stage of labor. This could reduce the risk of PPH by more than 40%, which is a big number. So carbetocin is superior over oxytocin and with respect to prevention of PPH, blood loss, Need of additional uterotonic, you don't need any additional uterotonic. Deviation in hemoglobin levels because there is no PPH. There is no need of blood transfusion, no perception of pain, and there are hardly any side effects. If we compare carbetocin with ergot alkaloids, then again, it has better profile, a better uterotonic. There is no need to give any additional uterotonic, and there is no need for blood transfusion, and it is very good in prevention of PPH. And when we compare with misoprostol or carboprost, so again, in respect to prevention of PPH, blood loss of after delivery, or need of additional uterotonic, it can be compared. It is superior over these prostaglandins analogs. Drawbacks of PG analogs, second line agent hai. They need multiple doses. It is not recommended by WHO, associated with significant increase in vomiting, diarrhea, and rise of temperature. So this is triplets delivered after 20 years of marriage. It was a very happy moment in our hospital, in the family of the patient. And this, another baby, this was a very, very complicated case. Like, it's a very rare case, panhypopituitarism. Male was suffering from panhypopituitarism. It was diagnosed when the the boy did not attain puberty. And then they consulted, and it was found that this boy is suffering from panhypopituitarism. Since then, he was in treatment with SGPGI. Then he got married. He came to me and he said, my count shows 0. And when I saw the history and the treatment part, I said, okay. So I started him on SCG and HMG. His count became 1 million, 5 million, 7 million. And then we frozen his semen sample, and we did ICSI, and the wife delivered a healthy baby. Now she is again planning for a second pregnancy because we have her embryo. We have her embryos with us. So this was a real achievement, getting a healthy baby in a panhypopituitarism patient. Thank you so much. Thank you for your patience hearing. Thank you.
Thank you so much, madam. Thank you, madam. Madam, let me introduce myself. I'm Prashant Khandeparkar, Dr.
Yes.
Khandeparkar.
Yes.
Can you hear me, madam?
Yes,
Yeah,
I can hear you.
Sorry, I joined the little. Yeah. There are a few questions, madam. Can I ask them?
Yes.
You know, one of them is that how common is PPH in these patients with high risk factor, especially uterine atony?
It is about, if we talk about PPH, if you like, PPH is 100%, and uterine atony is around 70% of all the patients.
17. So
yeah.
Quite
if
high.
I talk about PPH alone, like 100 patients are having PPH, then only uterine atony makes around 70% of patients. Then comes the trauma, and then comes other things.
Okay. Right, that's right. Even in uterine atony, I suppose multiple gestations is more common.
Yes, multiple gestations,
more high,
hypertension, yes. Like PIH, diabetics, obesity.
Okay.
They all make, and history of PPH.
Even
again,
fibroids
it is very,
to some
very
extent.
important.
Yeah.
And the patient who is already anemic.
Correct.
Pregnancy associated with fibroids.
Okay.
Pregnancy, history of myomectomy. All these patients have more chances of PPH.
Yeah. Even people with bleeding disorders, etc.
Yes.
They will obviously have this.
Yes, 1% bleeding disorder.
And when you use the carbetocin, what percentage of patients require additional uterotonic?
So I will not say that nobody requires additional doses or additional things, but yes, some patients do need it, and because we cannot repeat the dose, I have never repeated carbetocin in my patients, but then I have given them prostaglandins analog like misoprostol is my favorite.
Yeah, correct.
Yeah, it's a very good thing. You can give it sublingually or parectally, and it acts immediately and for a longer time. The only thing is that these patients have vomiting, diarrhea, and slight rise of temperature, and sometimes rigors.
That's right. But I mean, in emergency, these things will take a back seat, obviously. Yes. And, would it be a big statement if we say that carbetocin should be used prophylactically in every delivery to prevent PPH?
Yeah, I think there are few patients only where you should not give carbetocin, like the patient is having history of
Correct.
epilepsy.
Like you
And
said.
she is
Yes, yes.
she is hypertensive,
You did
uncontrolled
mention.
hypertension sort of thing. Otherwise, I think I mean we all have shifted to this now.
In patients with
So in my OT,
patients who
I
are
keep two
asthmatics, have you?
things. Yeah, in my OT, I keep two things. One is carbetocin, we give immediately, and second is misoprostol 600. For high-risk patients, misoprostol 600 also.
I
Combination.
sincerely pray to God. You never get a opportunity to use carbetocin. I mean, we know how it is. That PPH, when we were in hospital and in the units, PPH. I mean, I was in hospital quite some time back. That was,
I mean, it's a nightmare for all of us. Everybody has seen.
Absolutely.
और जिसने नहीं देखा है तो उसने obstetrics नहीं की है.
नहीं देखा मतलब किया ही नहीं समझ सकते. And the whole hospital is shaken. I'm talking about JJ Hospital in Mumbai.
Yes.
Can understand.
Yes.
The cold chain is a problem, I suppose, all India.
Yes.
Even in Mumbai,
Actually,
it's a
cold chain is a
because
problem
there's a
for
power
all
outage.
the injections because it's a tropical.
Okay.
Correct. And every time you cannot ask everything to be kept in the fridge.
No.
Yeah.
And even in the refrigerator, I mean, there's a power outage. It's not maintained. I mean, actually, in North India, there are many generators. In Mumbai, there are not generators.
Yes.
So it becomes an issue. Yeah. Now, another question is, if oxytocin is used in antepartum for dilatation of cervix, etc., can carbetocin be used postpartum?
So this is very, very important. Actually, these patients can be given carbetocin, but they act on the same receptors. Okay. So it is said that before giving carbetocin, you should think twice because this patient has already received oxytocin. So if she has received a lesser doses like 2.55 units, it's okay. You can give carbetocin. But if she has received larger doses of oxytocin for 2 days, 3 days to induce the patient, then I think it is better to go for other uterotonic because the receptor is the same.
Correct.
So
There'll be
carbetocin
receptor
will not
fatigue,
act on those receptors. Yeah.
There'll be a receptor fatigue ultimately
Yes.
when you're using. And have you used this drug in patients who are asthmatics?
Yeah, I've used because in asthmatics we cannot use prostaglandins. So I mean, this is the drug. This is the
so
drug.
Our choice is restricted in any case.
Yes.
Yeah, correct. I mean, this is all for the time being, madam. If there's anything else, we will definitely come back to you. It was a lovely, nice, crisp presentation. Thank you so much, madam.
Thank you.
Thank you.